Good morning. My name is Howard Herrmann from the University of Pennsylvania in Philadelphia, and my talk is on the SMART trial, the use of TAVR in small annulus patients. These are my disclosures. And this is an outline of what I'll share with you over the next 10 minutes. I'm going to discuss the adverse effects of TAVR with suboptimal hemodynamics, some of the lessons we've learned from small surgical valves as well as from TAVR, the incidence of small annulus in patients undergoing TAVR, some of the comparative hemodynamics of current TAVR prostheses, and then finish up with the rationale and design of a new trial that has just been announced and will be beginning very shortly. So this is a meta-analysis of 34 observational studies comprising 27,000 patients and 133,000 patient years of surgical prostheses in patients who had mismatch of the prosthesis to the patient. And what you can see that in patients, particularly with severe prosthesis patient mismatch, defined as less than 0.65 centimeters squared per meter squared, that there is an increase of almost twofold in all-cause mortality and more than sixfold increase in cardiac mortality in this meta-analysis of surgical patients. Some additional lessons that we've learned from surgery include the fact that less prosthesis patient mismatch is associated with better coronary flow reserve, more left ventricular mass regression, better exercise tolerance, and improved quality of life. And if that wasn't enough, we also have some evidence that prosthesis patient mismatch predicts structural valve degeneration in bioprosthetic heart valves. This study from Flaming and Associates, who followed 564 TAVR patients for more than 6 years, demonstrated that prosthesis patient mismatch was an independent predictor of structural valve degeneration with a hazard ratio of greater than 2. The incidence of prosthesis patient mismatch is shown in this editorial from Philippe Pibereau from a number of studies of both TAVR and surgery, and demonstrated that severe PPM, shown in the red bars, is fairly frequent, occurring in anywhere from 10 to 20% of patients after surgery and of TAVR. And most importantly, in the lower bars at the bottom, you see that severe prosthesis patient mismatch in TAVR trials was associated with an increased hazard ratio for mortality, anywhere from 1.2 to 1.9. This is a study that we did looking at the incidence and effects of prosthesis patient mismatch in the STS-ACC transcatheter valve therapy registry. We examined more than 62,000 patients who received commercial TAVRs between 2014 and 2017, and the incidence of severe PPM was 12.1%. Patients who had severe PPM had an excess adjusted mortality of 17% versus 15.8%, a hazard ratio of 1.19 that was statistically significant. And although the difference here appears to be relatively small, keep in mind that this is only at 1 year, and these curves do appear to be diverging. And I would expect that over time, this will have an even greater effect on subsequent mortality. We also know that many patients who undergo TAVR in the US have readmissions for heart failure. This is the overall readmission rate, which averages still at 30 days around 13%, even in contemporary series. And we showed in our study that patients who had severe patient prosthesis mismatch had a higher rate of heart failure rehospitalization in that first year. When we looked at the multivariate model of predictors of severe PPM, one of the most significant was small valve sizes. Valve sizes less than or equal to 23 millimeters was associated with a hazard ratio, an odds ratio for PPM of 2.77. Are small annulus patients and the use of small prostheses common? They are indeed. Here is some summary data from several studies looking at the surgical world. TAVR prostheses of 21 millimeters or less have been utilized in 20 to 40% of patients undergoing surgical AVR. If we look at the use of small TAVR prostheses in our recent randomized trials, we can look at the two intermediate risk trials, one with balloon expandable valves and one with self-expanding valves, and our two very recent low risk trials demonstrating the superiority of TAVR to surgery, both again in balloon expandable and self-expanding valves. And you can see that small annulus devices, small valves, 20 and 23 millimeter balloon expandable valves were used in about a third of patients in these two recent trials, and 23 or 26 self-expanding valves were utilized in about 20% of patients in these two trials. The incidence is even higher when patients are smaller, as they can be in Southern Europe and Asia. When we do TAVR in SAVR, it's very common to use small prostheses, 70 to 80%, and women, who make up about 90% of the small annulus population. If we look at which valve is better in this setting, we have data from randomized TAVR trials shown here for Choice, Reprise, Portico, and the two recent SCOPE trials that were presented. And what I've shown here are the effective orifice areas for self-expanding valves in red and pink, for balloon expandable valves in blue, and for the mechanically expandable Lotus valve in green. And you can see that the effective orifice area is larger for the self-expanding valves, and the mean gradient to the right is lower, again with the red and pink bars, compared to balloon expandable and mechanically expandable valves in these randomized trials of all comers. So these are not just small annulus patients. If we drill down a little more on the small annulus patient, what you can see here is that when choosing a TAVR prosthesis, this is from 3 core labs that pooled their data with best quality analyses of echo gradients and LV outflow tract areas at 30 days, and compared the smallest 2 quintiles of size for balloon expandable valves and self-expanding valves. The effective orifice area was smaller with the balloon expandable valves than the self-expanding valves. The mean gradients were higher with the balloon expandable valves, and the DVIs, the dimensionless index, was also lower with balloon expandable valves than with the self-expanding valves that have better hemodynamics. In the 2 low-risk trials that were just completed, severe prosthesis patient mismatch using the VARC-2 criteria occurred in 8.3% of patients in partner 3 and 1.1% in low-risk Evolut. These are not compared to each other, just the incidences in these 2 trials. And if you use an even more restrictive definition for severe PPM, the VARC-3 definition, it's still 4.6% in partner 3. As we think about expanding to these low-risk patients, and these are going to be younger and more active patients, we have to also recognize that exercise increases the cardiac output and the mean transaortic gradient, and the exercise gradients do go up more rapidly and almost exponentially as the effective orifice area decreases. So these differences may be even more important in these younger, more active, and low-risk patients. So some initial conclusions are that expansion of TAVR to younger and low-risk patients emphasizes the need for optimal hemodynamic results both in the short and long term. Awareness of these risks is important, thinking about severe PPM, low dimensionless indexes, and high gradients. And these risks, based on the surgical world, as well as some of the TAVR data that we have, indicates that patients who have adverse hemodynamics have higher mortality, reduced exercise tolerance, less left ventricular mass regression, impaired exercise tolerance, as I mentioned, and worse durability. And these effects will be worse in the younger and more active patients, and emphasized in those who have a small annulus, particularly women. So utilizing the largest prosthesis based on the annulus area and perimeter and manufacturer recommendations with the most optimal hemodynamics is going to be key to getting the best outcomes. And this is the rationale for the soon to be initiated SMART trial. The SMART trial, the acronym stands for Small Annuli Randomized to Evolut or Sapien, will be a head-to-head trial of the 2 commercially approved valves in the US, Evolut and Sapien 3, in patients who have a small native aortic valve annulus defined as less than or equal to 430 square millimeters on CT scanning. They will be randomized 1-to-1 stratified by sex to the Medtronic Evolut Pro or Pro Plus versus the Edwards SAPIEN 3 or SAPIEN 3 Ultra. This is a prospective, multi-center, international, randomized controlled study that will be conducted in approximately 700 randomized subjects at 90 sites in Canada, Europe, and the United States. Patients will be followed at 30 days and annually thereafter for 5 years. I have the privilege of being the chair and principal investigator for this study with my co-principal investigators, Roxana Mehran from Mount Sinai in New York and Didier Cheche from Toulouse in France. Some key aspects of this trial is that they will be all patients with a small annulus, but all risk groups, low, intermediate, and high surgical risk. It is an all-comers trial that will include bicuspid valves, but patient's anatomy must be suitable for transfemoral TAVR with both devices. And of course, it will include an echocardiographic core lab, a clinical events committee, data safety monitoring, and subject confirmation with a case planning committee. The co-primary endpoints are shown here. The first primary endpoint is mortality, disabling stroke, or rehospitalization due to valve-related or worsening heart failure at 12 months, a clinical outcome, and the study is powered for non-inferiority between the two devices. The second primary endpoint is bioprosthetic valve dysfunction, BVD, defined at 12 months, a measure of valve durability, and is based primarily on the VARC-3 criteria. It includes a criterion of hemodynamic structural valve dysfunction, meaning a mean gradient of 20 or more millimeters, non-structural valve dysfunction, which includes severe prosthesis patient mismatch, and moderate or more paravalvular leak and aortic regurgitation, valve thrombosis, valve endocarditis, or aortic valve reoperation or reintervention. There are other powered secondary endpoints as shown here. So we're very excited about this new trial that will help us to identify the best candidate valve and the best prosthesis for patients with a small annulus undergoing TAVR in a large head-to-head randomized trial. Thank you for your attention.